Is the red light on?
I think so. I think it's showing recording, didn't it?
Okay. Hello, sorry, excuse us, working with technical problems here. This is just to let you know we're just about to start. I think it is actually 3 o'clock, so we'll make a start. Okay, well, first of all, I'd like to introduce myself. I'm a final year PhD student. Heather is my supervisor and puts up with a lot. I'm in my final year, so I've collected quite a lot of data so far, but I'm just going to talk about a small part of it, or one part of it. And during this webinar, we will be discussing an outline of the whole study, which has formed the basis of my PhD research, and then discussing some issues I've encountered on recruiting people with learning disabilities. Then some findings from the interviews I conducted with people with learning disabilities. Finally, some preliminary findings from the first 2 phases of the study. My study title is Informed Consent to Genetic Testing in People with a Learning Disability, but before we carry on, I'd like to hand over to Heather to explain what, in particular, what kind of genetic testing we're talking about.
Thanks, Lesley. The reason that we decided to do this study really is not to think about genetic testing for a particular genetic condition, but we were more thinking about in the future, and actually currently now, the sort of genetic testing that might be available more commonly across the general population. So besides looking for genes that might predispose to common disease, which when we started this project we thought that there was a significant chance that those sorts of tests would be offered routinely. These days I'm not quite sure about that. I think it's going to be less applicable than the sort of testing that's involved in pharmacogenomics. And pharmacogenomics is a word comprised of obviously pharmacology and genomics, and it simply refers to the way that drugs are metabolized, utilized in our bodies according to variations in our genetic makeup. So we're not talking about changes in our genetic makeup that are mutations that are harmful in any way, but simple variations in the sequence of base pairs that we have that form our DNA molecule. And according to whichever variation we might have in a particular gene, that influences maybe whether we metabolize the drug quickly or very slowly, and at what dosage would be effective for us, whether a particular drug is better than another drug for the condition that we have. And some examples that we can use that are in use today are things like the psychiatric drug haloperidol, there are Herceptin for breast cancer, warfarin. All these drugs, the metabolism of them relate to particular variations in our genetic makeup, and there are very many more. The cytochrome group of genes have a particular role to play in the way that we metabolize drugs for common conditions. So we're not talking about treatment of genetic conditions, but drugs for common conditions found in the population. And we thought that as all members of the population might be offered these sorts of genetic tests, pharmacogenomic tests, then it was relevant to see how they might be offered to people with learning disabilities in our general population.
Thank you, Heather. So the aim of this study was to explore the information needs of people with learning disability, and hopefully by doing this to facilitate informed consent and give people with learning disability greater control over their own health. It has been shown that people with intellectual or learning disability experience health inequalities compared with the general population. In addition, these people have higher levels of health needs than the general population, and often these are unrecognised and unmet. So the health of people with learning disabilities is worse in many ways than that of the rest of the populations, and on average their lives are shorter. Research by Andrew Nocon from the Disability Rights Commission and colleagues provided a picture of these health inequalities and the aspects of health services that permit them. The study included morbidity, access to services, diagnosis, health problems and health promotion. And they found inequalities in all these areas, possible causes being professional prejudice, communication problems, inadequate time education, diagnostic overshadowing, and often an inadequate knowledge of learning disability. So the first phase of my study was carrying out a literature review on informed consent to healthcare interventions. In particular, it was looking at consent to healthcare interventions because there wasn't sufficient research to look at informed consent to genetic testing. And it was a systematic review which eventually included 23 papers. Sorry, I don't know why this keeps moving. I do apologise for that. 10 quantitative studies, 10 qualitative studies, 2 literature reviews and 1 mixed method study.
Can I just break in there a moment, please, Lesley? Because some people are having a little bit of a problem with getting either vision or audio.
Okay.
If you sign out, and come back in, you have to use a slightly different username. That often works. Check the sound system on your own computer. And if you're still having problem, you can contact Ray Jones as per the menu on the right hand side of the webcast page. I'm sorry for that, but as someone's said that they've gone out and come back in, and that does seem to help. Okay, thanks, Lesley. Sorry to interrupt.
Yeah. Okay. Right, we'll carry on. So from this literature review, I identified 4 main themes, and these are factors that may mediate the informed consent process. First of all, a person's life experience, and by that I mean their residential status. They might live at home with parents, they might live in residential care, or possibly, in fact a lot of them live now in supported living accommodation. Their educational background, that probably varies with the person's age. Those people with learning disabilities who are younger may well have had a completely different educational experience from the older ones. The medical history, and also a person's opportunity for decision making. This will vary tremendously. The second main theme was the interaction with healthcare professionals. Sorry, this computer seems to be moving my slides on its own. I don't know why. Interaction with healthcare professionals. First of all, the attitude of the healthcare professionals. How can that affect whether or not informed consent is obtained? And also how information is provided to the person, and or whether information is provided and in what format. Thirdly, the ability to consent, or loosely speaking, the person's capacity, i.e., can they understand and retain the information they've been given? Can they manipulate that information to come to a decision? And finally, can they communicate that decision? It doesn't need to be in writing, it can be verbally. Finally, the final theme is what I term the psychometric properties, and simply that is someone's verbal ability, for example, or their memory capacity, or their IQ, for want of a better term. So the findings from this review led me to conclude that there was a need for more qualitative research in the field of learning disability healthcare, and I felt that this research should be conducted if possible, in a real life situation, rather than the construction of vignettes, where vignettes are put together representing health situations. I think by researching in real life situations, researchers will have access to real emotions and people will react to a real situation, rather than the participant having to use their imagination to envisage a scene, and this could actually cause problems for people with learning disabilities anyway. Finally, I saw a need to explore the views of people with learning disabilities themselves and those involved in their healthcare, with the current emphasis on person-centred care and equity of access to services by people with learning disabilities. I consider it essential to explore the experiences and needs of the service users, as well as those of the people responsible for their care. Okay. The next phase, we're having trouble with this computer, I do apologise. The next phase of the study, following on from the review, I conducted observations of people with learning disabilities having blood tests in general practice. And the purpose of this was really to establish a baseline of current practice with regard to information giving, whether it was given, how it was given, and looking at the informed consent process for a minor healthcare intervention. The third phase was semi-structured interviews with people with learning disabilities, and the purpose of this was to identify their experiences and their attitudes concerning their information needs, their views on decision making, and what they thought about the consent process for healthcare interventions. This is the phase that I'll be concentrating on today. Fourth phase, it's a long study, isn't it? Focus groups. First of all, an online discussion forum for healthcare professionals. That's now been completed and was very useful, and I'm grateful to those who participated. A focus group for paid carers, which again has taken place, and that gave a different approach to the whole problem. It's interesting. And finally, I will be talking to family carers, which again it'll be interesting to see the differing viewpoints that family carers have compared with paid carers. Last of all, when I've completed all the other data collection, I hope to interview key informants, and I will be discussing the same topics as for the focus groups, and giving some of my findings, and hopefully obtaining some feedback from people who've got a lot of experience in the learning disability field. And you'll have to excuse me if I read from some of my notes here, because this is quite complex. But before I talk about your findings, I would like to say a bit about the recruitment process, in particular recruiting people with learning disabilities. Iacono and Murray stated that there was a need to protect vulnerable participant groups, whilst ensuring that demands placed on researchers are not so restrictive as to preclude valuable research. This is obviously something that the ethics committees are very much involved with. The same authors list special considerations for participants with learning disability. They say that they're vulnerable because of uncertainty about their capacity to consent to research. They can be vulnerable as a result of living in institutional care. And they also say that the voluntary nature of the decision to participate can be in question if there's an unequal or dependent relationship between the participant and the researcher or the person recruiting. There needs to be a balance between the autonomy of the person and their protection. It's also known that individuals with learning disabilities are known to exhibit a higher level of acquiescence than people without learning disabilities, and that can cause problems when gaining consent. In a research methods review paper published in November 2008, Melanie Nind, when considering the problem of gaining access, describes the crucial role of the gatekeeper and how this can work for or against the researcher.
Now, when we're talking about gatekeepers, we're really talking about those people who have a list of the inclusion criteria, they know what the research is about, and so what Lesley did was ask certain people to flag up potential participants based on a judgment that they made about whether the participant would be suitable, would have the capacity to consent to the research, and would be, not harmed by the research. So what we're interested in from our perspective to ask you today is about gatekeepers. Who do you think, when you're thinking about people with learning disabilities, who do you think are suitable gatekeepers? Should there be a gatekeeper? Should people with learning disabilities be recruited in exactly the same way as other people? Or if you think that a gatekeeper is a useful person, who is the best, or who are the best gatekeepers? Now we're going to just wait a couple of minutes to let you answer that. We'd like you to type your responses in, and then we can discuss the responses that you've given us. And I know out there are a lot of you who are used to working with people with learning disabilities and conducting research, or working with them in clinical practice. So if you could come back to us at who are the suitable gatekeepers.
Why does it keep doing
And I had a response from Nicole that maybe the gatekeeper is possibly a close family member, someone that the person's living with, and importantly, someone who the potential participant trusts. So the issue of trust seems to be important from Nicole's point of view. I'd be interested in other people's perceptions of that, or do you think it should be a close family member, or should it be someone outside the family who obviously knows the participant and has some idea of their capacity? Those of you who are watching who work with people with learning disabilities, I think your opinions would be really helpful here. So I'll give another minute or two for you to write something for us. another comment suggesting service managers when people with learning disabilities are living in a residential establishment, but that perhaps the service manager is well placed to be the gatekeeper. And Lesley, you've got a particular comment about family members versus maybe professionals.
I'm just wondering what people think about the idea that possibly family members, perhaps if a person with learning disability is still living at home, family members may make different assumptions about a person's capacity than perhaps someone who's further removed from that person, like a service manager or perhaps a manager of a day placement that person goes to. I think sometimes people have a different perspective if they're very close. So I'd like some comments on that, I think.
Do you think, Lesley, that there's an issue there about protection too, and that maybe the family or a professional, you know, it's not clear either way, but could be very protective, unduly protective of the person with learning disabilities?
I've experienced both in my recruitment, that I've had people who've been quite far removed who have been overprotective and have made an assumption that that person wouldn't have capacity, whereas possibly they might have done. But people who've haven't actually used family members as a gatekeeper, so I can't speak about that. But certainly the degree of overprotection has varied. I think maybe it might not be related to a person's role. It might be related to that person themselves. You know, their personal characteristics as opposed to their professional role.
Right. And we've got another couple of points here. Mary has written, does it have to be one person? Could a best interest decision be made by a group of people, including paid and unpaid carers and professionals? And that seems a reasonable suggestion. I suppose it's just pragmatically getting those people together.
I agree, Mary. I think that would be the gold standard, you know, that we could adopt, which would guarantee, I think, that the people we wanted to help us with research would have every chance of being included. But in practical terms, that could be quite time consuming. Later on I'll be telling you about, because the gatekeepers are only making very much a value judgment as to whether the person is likely to be able to consent. But then I'll tell you about the next stage, which again weeds out or filters out a few people who in fact don't have capacity. So, but I think that's certainly a very good idea, and I think it would be perhaps a way forward.
And Bronwyn here suggested an independent advocate possibly, but goes on to say in a later comment about arguing about best interests. And I do agree that maybe it's not so clear what's in the best interest, but actually one of the things that you've found is that people with learning disabilities actually felt that they wanted to contribute and it enhanced their feeling as part of society. Is that a fair?
Yes, the majority, well, all the people that I've interviewed have been very pleased to help. I think have valued the opportunity to speak to me and to actually put forward their views and their experiences to another person. So that's interesting. But also, just talking about Bronwyn, you talk about the hard to argue best interest in the case of a research project. The Mental Capacity Act says that if you're working with people who don't have capacity to consent, you have to convince an ethics committee that your research is going to benefit that population group as a whole. So rather than it benefiting the individual with learning disability, the research needs to benefit that service user group or group of people as a whole. So you know, that's another aspect to it.
And of course, although we're talking in a research context, I think a lot of these topics, a lot of these issues are just as important or more important and apply equally to clinical practice and people making consent decisions in clinical practice.
Yes. Okay.
Thank you for your contributions there. That was very useful.
So I'm just going to go back. Just to go back to give an example, and you may have comments about this, that I was using a gatekeeper, or using gatekeepers to find my participants, and the thinking behind that is that there is less danger of I think of coercion, of people being coerced by me as a researcher. But I actually felt that possibly service users, for example, if someone is in a day centre or a place where they go during the day, and the service manager asks them if they would like to help with research, I have the feeling personally that they'd be more likely to agree to that person than they would to me as a complete stranger coming and asking them to help with my research. So I'm not really sure in that situation whether that's a valid argument for the use of a gatekeeper, because there may well be a perceived difference of power. The person with learning disabilities may well see that person, their manager, as having more power than them, and may well agree to take part, whereas they might not do if I ask them. So, okay. Right, so the next stage, once I had been introduced to a potential participant, I then held a consent meeting with a supporter of their choice, where I explained the nature of the research, and I used an information sheet in accessible format, which I had help with from local speech therapists. Thank you, Mary. I then asked the participant to feed this back to me in their own words, and at that point, the supporter, who knows the person well, the supporter and I discussed whether we thought that person had capacity to consent to the research, i.e. whether they understood what I was asking them to do, whether they understood the advantage or the disadvantage, and the fact that they could withdraw if they wanted to, the normal rights that the person taking part in research has. In all but one case, we agreed that there was capacity in both stages of the research, the observation and the interviews. But there is one anomaly which I find quite interesting. A particular participant, who I shall call J2, was nominated by a gatekeeper from the learning disability team. But on conducting the consent interview with a supporter present, we agreed that she didn't have capacity to consent to be observed having a blood test. She didn't seem to grasp what I was wanting to do. Apologise, the slides are slipping again. So we didn't include her in that stage of the research. Later on, when I was embarking on the interview phase, I used a different gatekeeper from a different organisation, and again this participant was suggested to me as being likely to have capacity to take part. So I then conducted another consent interview with a different supporter, a supporter who also knew her very well from that second organisation. And on this occasion, we decided that she did have capacity to agree to be interviewed. This really illustrated to me the complex nature of consent and capacity assessment, that how it has to be specific to time, specific to a particular decision. After all, she was consenting to two different things. Also, I think illustrates that it's possible that different people can judge capacity differently. Now that may be rather controversial, but although there are certain tools that you can use to assess capacity, I think it always comes down to a subjective assessment. But health professionals, please correct me if I'm wrong on that one. Okay, now. Right, so we were going to have an activity at this point, looking at your own experiences of the healthcare consultation. For example, information giving, the role of the support worker, the relationships between support workers and healthcare professionals and the patient, valid informed consent and attitudes of healthcare staff. Now, obviously I don't know what all of your backgrounds are. There may be healthcare professionals who are also academics, there may be pure healthcare professionals or pure academics. So if any of you have got any thoughts on any of this, it'd be really interesting if you could type in your responses in the same way you did earlier, and perhaps we can discuss them at the end, if that's okay.
Yeah. So we're not going to stop and wait, but if you've got any particular experiences you think are relevant, please type them in and we'll come back to them.
Thank you. Okay, and before I talk about the interview findings, I'm going to just tell you a bit about the observations that I made of people having blood tests in general practice. Five main themes. The first one was the emotions that they showed, and I'm just going to give you some little examples of what I noticed. There was fear and anxiety, and sometimes expression of pain. People saying, "Oh, I hate this bit," and as the nurse inserted the needle, which is quite understandable, really. Others expressed, put on a show of bravado, I think possibly for my benefit because I was sitting there video recording it. And lots of them showed visible signs of relief when the blood test was over. Secondly, the information aspect of the consultation. It was interesting to see what information was provided for patients prior to the blood test procedure. Some were given no information whatsoever, but were simply asked if it was okay to do the blood test today. Others were provided with a fairly detailed explanation of the reason for the blood test. For example, the one we're taking today is to check your thyroxine levels because you're on medication for your thyroid. So, though it's a simple explanation, it's probably sufficient for its purpose. In one case, there was a participant that had the reasons for the test explained to her after the blood was taken. The consent process. I was particularly interested to observe the consent process, but I did wonder if just stick it in there constituted informed consent.
So this was the participant saying to the nurse,
yes,
just stick it in there.
Yes.
Yeah. Okay.
I think she wanted to get it over with, but but that was the only part of the interview that I could see that actually represented any form of consent to the procedure. Another nurse just said quite simply, "We're going to take some blood this morning and we'll check your kidney function and your liver, cholesterol and your blood count, and it's the same time every year. Is that okay?" And the patient said, "Yes, right, that's fine." So again, a certain element of consent there. It was obvious both in the observations and in the interviews that there's a complex relationship between the three people: the person with learning disability, the healthcare professional, and on some occasions the support worker. Without exception, in the observations that I made, I noted a warm, friendly relationship between the patient and the healthcare professional, and regardless of what else I was doing, looking at information and consent, but equally there was an obvious rapport between the support worker and the participant in all cases. One participant even expressed her opinion of the service she received while she was in the consultation, and Heather's just going to read this out for you.
Yes, this participant said about her support worker, "Oh, he's
actually,
a lovely..."
About the doctor, actually.
About the doctor,
it's
about
yes.
the doctor, sorry. "Oh, he's a lovely chap. I like him. He's very, especially with my stump and all that, he's helped me a lot. He's written some good letters to some nursing homes and all that for me too last year, and I must praise him for that because he was very good."
It was only in the interviews that participants actually disclosed examples of what I would consider poor practice, and I will discuss these later. There were various strategies used during the consultation to facilitate what could be seen by the patient as a difficult procedure, and these were used by both the patient and the healthcare professional. The first one was distraction. This seemed to be used by the healthcare professionals to try and distract the person from the blood test procedure. In one case, the SFIG dial was placed in the hands of the patient and she was asked to look at it to make sure it was working properly. In another, the patient was asked to look at the photos of the doctor and his family on the notice board while she was having her blood taken. The second one was rapport. That was obvious, often just a case of social chit-chat, catching up on the patient's news, etc. In most cases, because the patients were well known to the healthcare professionals, this appeared to happen naturally. Finally, a good sense of humour appeared to oil the wheels. One patient who had quite an acute sense of humour, the nurse had said, talking about having problems finding the vein, said, "It's playing a bit hard to get, I think." And the patient said, "I get the point." And the nurse obviously didn't quite get that, said, "Sorry?" "I get the point," he said, and he laughed at his own joke. And they both laughed together, and she said, "You're on form today, aren't you?" So, you know, they had a good rapport, those two. Right, now I'd like to describe some of the themes which I uncovered from the interview data, which obviously was talking in more depth to the patients, the participants, themselves. Several participants expressed fear, either explicitly in the interview or implicitly by body language in the consultation. In the first case, the patient denied she was frightened having a blood test, but when observing her, I noticed that she was showing fear. Her body language expressed anxiety, and she told the nurse that she hated that bit. I just got a little example here I can show you. You can read that. I don't think I need to read it to you, but she was shouting. She didn't want it done, and she obviously wanted a local anaesthetic, but that wasn't forthcoming, and I think it probably wouldn't happen in general practice. But in the interview, when I asked her how she felt when she went to the doctors to have a blood test, she said, "Fine, fine. Not afraid of nothing, me not. I'm brave." So that was interesting to compare the two findings. Another participant was full of bravado when in the consultation, and said, "Carry on, nursey," and which was again another sign of her sense of humour, I think. And later on in the interview, said that she was petrified of needles, so she was putting on a brave face in the doctor's surgery. Many participants were keen to show that they were capable and independent, and some were keen to say how they wanted to be treated. I can give you an example of this. This particular participant felt that because she could read, she didn't want pictures, but it also I found it interesting, her attitude to other people with learning disabilities who couldn't read, and felt that it was babyish to have pictures. She also said that when she went to the doctor, she didn't want to be treated like a child, and I thought very interesting was the fact that at the end she said, "Because you're just like anybody else then." And this to me indicated how people with learning disabilities really do want to be seen as in the same way as everybody else, and treated the same way.
Treated, yeah, yeah.
Most people had a very good relationship with their GP surgery, and there was often a high level of trust and acquiescence. I did wonder how much this differed from that of people without a learning disability. Again, I think I have an example of this. Right, this, as you can see, this patient had a huge amount of trust and had faith in her doctors and nurses, and I think, like some of the other participants, would agree to have anything that the doctor suggested, which and she was very well known to her surgery and had been going there for years, but had great faith. And also, she also mentioned to me in another part of the interview she felt the same way about the hospital, the local hospital. Another participant said that I could trust my doctor 100%. He knows my family and I trust him. You know, if he says, blood test to check on your bloods, like, for example, sugar level or anything like that, I sit and do it. You know, I trust him. Finally, if I could just mention one example of experiences to show that experiences weren't all good. One participant recalled that he was prompted by the supporter, I have to say, but he recalled how a doctor that he saw was rude to him and called him mentally retarded. And although the supporter had reminded him of this event, I could see that participant, as he was talking to me, was getting quite distressed and angry about the fact that he'd been treated in this way. So again, they don't want to be treated like that, and they shouldn't be. So, okay. The next one is about the role of the support worker. I say supporter, I mean, because you know, they're called. You've got the key workers, the support workers. sometimes parents. So just supporter using that as a generic term. The majority of participants had something to say about the role of the person who supported them, whether it was a member of the family or a paid support worker. One, talking about his mum and dad, said that he likes to have his mum and dad with him, and I asked him how that made him feel, and he said, it makes me feel all right. I said, well, how do you think that helps then, having someone with you? And he said, it makes me feel very happy, which surprised me at someone going to the doctors feeling happy, but there you go. But I just find it helpful. He obviously really valued the support that his parents' presence gave him. A second one, again, said that it helped him to feel secure in the consultation, although he said he didn't always have someone with him. But interestingly, this person said that he sometimes goes on his own. He said when he takes someone with him, it makes him feel secure. But he also said, I said, does the support worker sometimes explain things to you if there are things that you don't understand at the doctor's? Would a support worker help you? And he said, they would help me, but if I can go into the doctors and explain myself, then that is going more forward. And I thought this was a really significant statement, because what he meant was that he wanted to, later on we discussed this, and that he indicated that he valued becoming more independent and going on his own. Other people said that their carer knows and understands and can explain what the doctor has said afterwards.
Can I just break
yes,
in there,
please
Lesley?
do.
Because there's a really interesting comment from Peter, who's said that everyone else can read this but you, but he has said, I've always been fascinated how people with a learning disability, like all others perhaps, have to have some people they can feel superior to, like talking about the babyish images,
Yes,
you know, that
yes.
that children might require that, but not me, and maybe that's an essential for self-esteem. And I
agree.
I think that that's a really pertinent point.
Yes.
We all need to feel,
Yes.
you know, that we have some esteem and we're esteemed by others, don't we?
That wasn't the only example.
No.
I mean, we've had other examples which I could read. I can think of one straight off, where one of the participants it was actually in the consultation, not in the interview, but she was telling the practice nurse how she helped someone at the drop-in centre with his computing, and she and also sometimes because she could read, she would read things to other people who couldn't read. So that really was boosting her self-esteem, that she was, and she wanted someone to know that she could do something better than someone else. So, and there are lots of other examples too. So I think you're absolutely right, Peter. Yeah.
It does bring to the fore to us as practitioners, though, to those of us who are working with people with learning disabilities, getting that balance right is quite a challenge between presenting information and you know, talking in ways that we think will be understood, but not talking down to people, so not patronising them. And I think sometimes that's quite difficult for us to judge.
I should imagine. I mean, I'm not a healthcare professional, but I am a parent, and I think it's very easy to slip into that patronising, overprotective mode when you are dealing with them, and that's hopefully something that will.
None of us likes to be patronised.
No.
Do we?
No.
Okay,
Exactly.
thanks, Peter, for that.
Okay. Finally, it was quite clear that the majority of people I interviewed had an opinion about how they wanted information presented to them. I asked people how they wanted things explained, how doctors should explain things, and someone said, sorry.
Are we talking now? We're talking about genetic information, or simply general
just
healthcare information?
General, yes.
Yeah.
In fact, that's not. We can talk about that in a moment. But there are complaints about the sort of long words they use. Sometimes they say that it's, one of the participants said, because some people can't, don't know what they're saying, talking about. So that's the first thing, the long words. Someone else said, could they speak? And he said, slowly, not in a load of jargon. And again, I think we all tend to do that. Someone else said, people who've got learning difficulties and that, like me, and that got problems with their words and that, and explaining it to the doctors. And I said, well, how could they make it better? And she said, could they please talk a little bit slower and not too quick? And she was very, very, she was gesticulating like mad when she was talking to me about that. Someone else suggested, I asked the last person I interviewed actually, I said, how would it be best for a GP or a nurse to explain something to you? Would you rather he talked to you, or gave you a leaflet, or any other way? And this person said, sometimes even a DVD to watch, on the telly. That would be one way of doing it, which actually I found very reassuring, because I have produced a very simple DVD to explain pharmacogenomics to anyone actually, but in particular aimed at people with learning disabilities. To go back to what you were saying, Heather, I mean, I asked all my interviewees, I asked them whether they'd heard of genes. A few had, but the majority hadn't. So I think, explaining pharmacogenomics to someone would be fairly difficult, but I don't think they need the science behind it. They just need to know why it's being used. But I will also say that speaking to support workers and even nurses, they will also need help in having it explained to them. And when I mentioned taking the DVD back to show people, support workers said they would also like to see it. So okay, I think probably that's all on my findings. So really, just to summarise, and these are preliminary findings because I've got more to do, but these are from the observation and the interviews. So the themes that we're looking at that may well influence informed consent to healthcare interventions are people's emotions and their behavioural characteristics, the information that they're given and how it's given, the way the consent process is approached, their relationships with healthcare professionals and with their support workers, their self-identity and their image, and as we've said, their self-esteem, and the coping strategies that they use. I was going to press the button then, and it did it itself.
It's predicting your every move. Yeah.
Oh, sorry,
no, that was too early.
So the next steps for me are findings from focus groups. I've got one more focus group to do, and then I can look at those, and the feedback from key informants. So a little bit more to do, but nearing the end. So I'd like to say thank you very much for listening, and perhaps we could, I don't know whether Heather's been looking at the comments, so whether we've got some discussion going on here, that would be great.
Well, we haven't had any actual comments about practice or experiences, but we have a comment here from Mary. The challenge is to get the balance right for the individual, and not to be patronising, but to simplify the information that we give. And is that any different to anything that we should be doing in our communication with any person? No, really,
I don't think so.
No. While you were talking, I was making a comment that perhaps we could go into now about how pleased the participants with learning disabilities were to be given the chance to contribute to the scientific knowledge, and you might want to relate. One comment from one participant really sticks in my mind, that you might want to tell the story.
We're talking about the gentleman who said he would like to do what I was doing. No,
no. I was talking about the young lady who said, gave you some information and said to you in a very positive way, I think you'll find all that's enough for your purposes. Yes. To answer the research question. Yeah, she really she wanted to please me, and she also wanted to be seen to be doing really well, and she obviously felt there was a right answer and a wrong answer, but she was really giving me as much information as she could think of, and in fact that applied to a lot of them. They were giving my questions a lot of thought. And actually the data that you've gathered has been extremely rich and useful data, and I think for the whole period of this project we've been struggling with making sure that we weren't violating the rights of people with learning disabilities, but giving them the opportunity to participate. And it certainly for me has come out on the side of, they really do need to have the opportunity to contribute rather than other people making those decisions for them.
No, because I do feel that had I had the opportunity to recruit myself directly, I would like to think I could have got some more participants, but without coercing, because as we've just said, a lot of them are keen to help. So I was restricted by the judgments of the gatekeepers that I used, but they have all been very helpful, and I've had some very valuable opinions and from the people with learning disabilities, and I've learnt a lot from them too.
And one of the hardest things was, I think, when you had some carers and people with learning disabilities who were willing to be involved, and in one case a GP made a decision that they couldn't be because that person, the GP, didn't feel that it was appropriate. And that was quite a hard moment, wasn't it? Because it felt like their rights were being violated by the gatekeeper.
Yes,
in fact,
because they'd got through one gatekeeper. They'd been suggested to me, but yes, on approaching the practice, I was not given access to actually observe them. So I felt that was a wasted opportunity, and probably inappropriate. But then I was allowed. I could interview them, obviously, but I just couldn't go into the practice. So
it contrasts a little bit with a comment that Peter's just made about, since he trained in the 70s, people were simply included without their consent, and undertaking inclusive research offers new challenges, but is clearly the only acceptable way to go forward. And maybe the pendulum swinging to the other way a little bit of people now not being included because we're so protective of their rights, or some professionals are protective of their rights. And I think it's tricky.
There's been Iacono and Murray, who I quoted earlier. They have in particular Iacono, and she's written quite a lot on the role of the ethics committees, the NHS ethics committees, and whether they are being overprotective, and whether therefore some people with learning disabilities are actually being deprived of the opportunity of taking part.
Yes.
And also how representative can the research findings be if certain groups of the population are being excluded. So I think it's really important.
Okay, well, we haven't had any new comments for a minute or two. Obviously, Lesley and I are happy to stay here to answer any questions or comments that you might want to put to us, but that's the end of the presentation that we've prepared today. And if you are leaving us now, we appreciate very much your presence and your input, and thank you for your interest in this topic. Hopefully next year we'll have another one with the final results from the research project. I suppose I can just say there is a webcast like this once a month from the University of Plymouth, usually on the first Tuesday of the month, and you're very welcome to join any of those webcasts. The list of them is in the timetable on the Faculty of Health webcast page, so please feel free to join us, or anyone else who's presenting. Alison has asked if we had any experience with court-appointed deputies during the project, and I don't think we have at all. No, not at all, Alison. And maybe that's a feature of the fact that this was research. And
I wonder if Alison's thinking of those as gatekeepers. Is it?
Maybe.
Yeah, I suppose. It would have been difficult for me to identify those, because I would first have had to identify the people.
Yes, before
yes.
going. Yes. So it's the wrong way round in a way. Yeah. Do you mean you would have first have to identify the person with learning disabilities, and then
I would become
court-appointed deputy?
Yes.
Yeah. And we were going about it the other way.
In retrospect, I think it may have been useful perhaps to approach to identify people via the GP practices, because they do have to keep learning disability registers. But whether that would have been, how difficult it would have been to get NHS ethics consent to do that, permission to do that, I don't know.
Alison's comment just reminded me a little bit about the applicability of this work to other work, because part of my other research has been looking at consent for screening, antenatal screening during pregnancy for congenital abnormalities in the baby, and of course, a proportion of people who are pregnant have learning disabilities, and we've actually found that consent for the screening process is often not informed, and a lot of the materials are written in quite detailed language. So this consent issue is not only about pharmacogenomics or testing for susceptibility for common diseases, but also everyday kind of procedures during a normal pregnancy.
I think, am I right in thinking, the Mental Capacity Act, the Code of Conduct, I think says that with regard to the amount of information, it has to be enough information but not too much. So, it obviously, depending what the decision is, there shouldn't be too much. It should be adequate. I think adequate is the word they use. Adequate for the person to make the decision.
And that's another issue, isn't it? Because what's adequate for one person might not be for another. So we could start off a whole new discussion there. Okay. Well, our chat room seems to have dried up a little bit. I think we're going to, on that note, say goodbye.
Well, thank you very much.
We'll leave the chat room open for a moment, so if you have any further questions, please feel free to send them in. But thank you very much for your company.
Yes, thank you for listening.